If you'd like to introduce yourself, and then if you wish to make a short statement of up to 5 minutes long, and I shall keep you to time in terms of when you have a minute or so left, and then we will have a number of questions for you after that. So feel free to introduce yourself and make the opening statement. Thank you.
Yeah, thank you. My name is Paul Darragh. I'm an associate specialist in general medicine, working in Antrim Hospital and the Mid-Ulster Hospital. And I'm also chairman of BMA Northern Ireland Council. And I think I'd first like to start, Mr. Chairman, members of the inquiry panel, to thank you for the invitation, in fact, the opportunity to represent the views of the BMA and its members. The BMA is a professional organisation and a trade union for the medical profession across the United Kingdom with over 150,000 members. And we represent about 90% of the medical profession in Northern Ireland, some 6,000 members. I think this inquiry comes at a particularly opportune time. The health service faces unprecedented challenges. An increasing proportion of our population are elderly, often with complex medical conditions and needs, social and medical. There's a rising tide of obesity with a related rise of diabetes, heart disease and many other conditions. There's a cost of new medical technologies, drugs, etc., and increased patient expectation. And all of this on a background of ever tighter financial constraints. Just to actually maintain the services at the present level would require a 4% above inflation rise year on year, just to maintain the service. And what we're facing at the moment is 1% per year, which is real terms is a cut, even though we're supposed to be ring-fenced. Our emergency departments have been called the canary in the coal mine, but I think one can see the stresses and strains affecting all aspects of our healthcare system, not just our ED departments, general practice, secondary care within hospitals and community care. And this situation is not unique to Northern Ireland, but it's true across the United Kingdom. The BMA wants to remain true to the founding principles of the National Health Service. We want to see a high quality, safe, patient-centred service, free at the point of delivering based on need. We want to see that health service at the centre of the programme for government, with independent review of policies, processes and senior management. Strategically managed with effective long-term planning and, importantly, resource management using evidence-based policy. Led by health service professionals, funded in accordance with evidence of need, invested in and future-proofed. With proper infrastructure and workforce in primary, community and secondary care settings, taking account of the problems that I've already alluded to with an ageing population and increasing levels of chronic disease. We'd like to see it designed to meet future service demands through effective workforce planning, focused on a partnership approach to commissioning, free as far as is possible from private sector involvement, transparent with effective patient representation, lean in terms of processes and bureaucracy, making best use of information technology to improve efficiency, manage risk and record patient outcomes, integrated regarding health and social services, and importantly, outcomes focused and not driven by targets. We've seen the problems when our culture, our NHS culture is driven by target and not by outcome, not having patient at the centre. As said, the one thing that we do stress is a high quality service, patient-centred health service, a first-class health service. We've heard recently in comparison throughout the world how well the NHS compares with systems in other places such as Canada, America, etc. We want to see medical leadership, participation by the BMA. We hold a unique position representing grassroots doctors across the entire spectrum of medical practice. And we think that using that expertise, we can help deliver a better patient-centred service. Not only do we want to see effective policies, but policies are just pipe dreams unless you have the resources to follow policies. And resources much follow policy. Thank you.
Okay, Paul, thank you. You were very clear there in terms of the key resource challenges and the issues there. I wonder, though, if you'd outline for us on the non-resource side, what do you think are the key issues facing your members in their work in emergency departments, and how you would tackle those issues?
Oh yeah, a massive layer of problems. As I say, increasing demand, and one way that the BMA has tried to help with increasing demand is patient education. Very often a lot of the referrals to our A&E departments or ED departments are self-referral. So we want to educate patients to make the best use of the services available, and for example, to avoid the winter pressures, and as you know, winter can be a particularly hard time with chronic respiratory problems, etc. To ease the winter pressures, in conjunction with the board, we participate in the Choose Well campaign, so that those attendances to A&E departments were appropriate. Our GPs are working together to see how services can be delivered in the community more effectively. And I know that they're working with the Minister and proposing networks of GPs or federations where these services can be provided in the community rather than having to resort to secondary care and putting pressure on our ED departments. Within the ED department, there is a problem with recruitment and retention. We want senior doctors there. We want senior doctor triage. We want senior doctors supervising junior doctors, so junior doctors are not left on their own having to deal with it. And so one of the problems we have is recruiting and retaining doctors. So one thing that we need to address is the work-life balance within ED departments. We don't want to have the situation where doctors are trained at great expense and then they, because of pressure or whatever, then disappear off to Australia. As has been an increasing trend. So we want the right number of doctors with the right training in our ED departments, and that leads us on to another issue, workforce planning. We have been advocating proper workforce planning. Now, we have heard from some of our colleagues in the department that workforce planning is akin to a black art. That may be so, but it's a black art that we need to get right if we're to deliver the service that the people of Northern Ireland need. It means planning not only for the services that we have now, but projecting for those services several years down the line. So we are engaged certainly in and have been advocating for proper workforce planning. We're also engaged in the Shape of Training review, which is looking at how doctors are trained and training, as I say, the right doctors for the right place and have adequate training. So we're engaged in that as well. The other thing we need within our ED departments is communication. We need communication between our doctors so that our ED doctors don't play what some have described or end up describing as consultant ping pong, trying to get a consultant in within the hospital so that they can discharge the patient and transfer the patient onto the ward. When the patient needs treatment, they have to be able to get up there. So we need to improve communications between our doctors. If a patient can be managed in the community after initial assessment in our ED departments, then we must be able to transfer them out appropriately and with support into the community. So we need to look at that. We also, as mentioned, need to look at the arrangements for transferring patients into our hospitals. Now, one of the problems we have, and we have things like trolley waits, is because we don't seem to have enough beds. And that can be due to the fact that, do we have enough beds for our patients? And that's when we're looking at reconfiguration of the acute services, that's something that we need to look at and to consider. Do we have enough beds for our patients? Are our patients being discharged promptly? But it's not only promptly, it's safely. We don't want to discharge patients out just so we can create a bed so that patient will end up having to come back in again. There's quite a bit there, and we're looking at and trying to engage in all aspects of our emergency departments.
Okay, I have one other question, which is you've alluded to the recruitment and retention issues. Two things, I think. One, in terms of emergency department, what do you think could be done differently to restore a work-life balance and recruit and retain? But I'm also interested in GP out-of-hours services, how you would see that kind of 24/7 availability of care and your members' roles in minor injury units, how you recruit and retain in those areas where you're talking about working, in some cases, quite unsocial hours. So how would you advocate dealing with recruitment and retention in all those different parts of the ED and ancillary services?
I think all these aspects are interconnected. I think it's going to be difficult to recruit and retain people in an environment which is pressured, which they feel under pressure, in which they feel that maybe they're not able to deliver the service that they want to do and to give to a patient. It's very difficult to work in an environment where you see that you're not able to give the care that you would want to give to a patient, that you're not able to give the care that you would want to give to a relative, to your mother, to your sister, to your brother, to your father, to your grandfather. That's not the sort of environment you want to work in. You want to be able to have an environment where the resources are there and you can give that care. So I see that as interconnected. To be able to improve the conditions there, I think you would not have a difficulty retaining people in there. You would not have a difficulty keeping people there. One aspect that's being looked at, for example, is an increasing role for our SAS doctors, our SAS doctors, and I'm sure that's probably been mentioned before, and that's the staff grade specialty doctors and associate specialists, and they would be a career grade. They're not a training grade. They're senior doctors who are not consultants, they're not trainees, and their career would be spent in emergency departments. Now we need to realise that if we are going to have those doctors, that their role is recognised, their seniority is recognised, and also that they are trained appropriately. They mightn't be a training grade, but like all doctors, they require support. So they require time, we call it SPAs, or supporting professional activities, so they need time scheduled in so that they can have study built in, and they are enabled to not only retain but improve their skills. As regards GP out of hours, I know that our General Practitioner Committee, our branch of the BMA, is engaged in speaking to the Minister to see how GPs can take ownership, if you like, of out of hours services, and I think that is being negotiated with the Minister at present.
Okay.
As regards 24/7, a lot of consultants already work 7 days a week, in the sense that they already work weekends. They don't just work 9 to 5 Monday to Friday. They would be working on weekends at rota. One of the things I think that when we look at 7-day working, what is meant by 7-day working? Do we mean the full range of services that you would have on a Monday, Tuesday, Wednesday, Thursday and Friday on a Saturday and Sunday? Because if we do, we need to look at the implications of that. You need to know that not only do you need more consultants and more doctors, but you also need more porters, more nurses, more secretarial staff. You need more diagnostic staff. You will need, and you will not be able to do this without an increased rise in finances. And there are some people who are talking about 7-day services without any input into being able to pay for the extra staff, or to have the extra staff there, or to be able to pay for the extra diagnostics, the x-rays, the CT scans, the blood tests that would be necessitated by that service. And I think you have to be realistic about that.
Okay, thank you. I'm going to pass you over to Marion.
Dr. Darragh, I have 3 questions, generally in the area of participation and monitoring and responsiveness to the need. And I'd like you to start off by looking at how the BMA is engaged with the department in its recent reviews of emergency health care, and how have members been enabled to contribute to the implementation and monitoring of the recommendations of those reviews?
Well, our members, the BMA itself has engaged on several levels. At the time when the Minister announced that he was looking into the situation in our ED department, specifically following on from the problems at the Royal Victoria site in January, we asked to specifically speak with the Minister. And so representatives of the BMA and the various committees, there will be representatives of general practitioners, secondary care physicians, SAS doctors and junior doctors met with the Minister, the Chief Medical Officer and the Permanent Secretary at the time. And we have to give forward our views on the problems affecting EDs, and also how we would see the solutions, which would be, again, as reiterated, basically that it is much more patient-centred, that we look for outcomes rather than targets as such, and that we're more driven with giving the best possible care to our patient, that there's greater engagement from physicians, those actually engaged at the front line, and that there are proper resources made. Now, we have had a commitment from the Minister that we will be meeting with him again in the near future to discuss this further. Quite apart from that, the BMA has also engaged in the ED summits, which were organised by the Royal College of Emergency Medicine, and have contributed to those and to the 60-day follow-up event, and also the RQIA workshop as well. So BMA representatives have been at all of those, and so we have been engaging in those. Quite apart from that, of course, we have sort of also been active in putting forward our views as to the issues and how we would address them in the media, whether that be radio, TV, or the written media, and also electronic as well, of course.
In terms of the implementation of those recommendations, to what degree do you feel ownership in the way it's been taken forward?
I think there's room for improvement.
Pardon?
I think there would be room for improvement.
In what way?
I think we need to be more actively engaged in the implementation and see how it's going. But again, this is one of the reasons why I think we would call for medical leadership, much more greater medical involvement in this. And it's one thing, if we are to avoid some of the problems that we've seen identified in the health service within recent years, I mean, one of the calls of the Francis report was greater medical engagement, and we need to have medics more at the centre of these issues. And more acting to deliver the best possible care and acting when needed as a patient advocate.
And do you have processes in place to provide feedback on healthcare provision to the commissioning board or the department on a regular basis?
We are engaging, and we will be meeting with the permanent secretary. We have ongoing meetings with the board, more specifically around transforming your care, but we will be seeking further meetings to push this.
Right. And my final question really is in terms of patients with particular health needs who go to emergency departments, such as children or those with mental health needs or the elderly. And I'm wondering, what's the current view of the BMA in terms of the operation of the emergency departments for those particular client groups?
I think we have to be aware of the special needs of these client groups. And I think that is another area that we can look at, whether the patients need to actually go through ED departments, or can there be some way in which they can be facilitated by either special teams coming down to see them in a particular area so they can be accessed, or whether they can be assessed on the wards, those wards specially set up for their needs.
Thank you. Thanks.
Paul.
Thank you very much for your time and for your help. A human rights-based approach to health requires a certain sort of health governance.
Mm-hmm.
Governance with features of participation and transparency and accountability. And I wondered whether you had any reflections on how health governance could be enhanced, could be improved in Northern Ireland. Emergency care being, of course, one of the beneficiaries of health governance being improved. So, do you think there are ways that could be there are reforms that could be made to enhance health governance, transparency, participation, accountability? Yes,
I think I do. I think, and going back again, I think now I talk in broad terms about sort of medical leadership and clinical leadership and engagement, but very much part of that is that medics, etc., are engaged and that they are part of it, and it's something that we must work together with management. And that not only, I'm not only talking about the broad strategic thrust of things and things that are implemented, but I mean even down as regards the teams on the wards or in the ED departments, so that there is a greater responsibility, a greater a feeling of responsibility and ownership, that we look at what we're doing, we analyse what we're doing, and that we, subject to the current strictures of appraisal and revalidation, take a critical look at what we're doing.
And do you have any suggestions on what, in practical terms, I mean, maybe not, Darragh, and that's fine if it's the case, but do you have any suggestions in practical terms what could be done to strengthen health governance, or maybe on balance it's pretty much okay? A bit more participation here, a bit more participation there, but perhaps on balance you think it's not a bad health governance arrangement. But if not, would you do you have any suggestions on how it might be, specific practical suggestions on how it might be enhanced? Perhaps you need to think about it.
It may be something that we need to think about and come back and look at our policy area on that.
Thank you. The commissioning of healthcare services, I'd be interested to know the extent to which your members feel, I know it's difficult to generalise, but the extent to which your members feel involved in the commissioning process. Do you get a sense that they're a bit stymied, they're a bit frustrated? Here they are at the coalface, and that they're not being given sufficient opportunity to convey their views in the commissioning process towards the board. Do you have a reflection on that, please?
Yeah, very much so. I think that was what was called a leading question, but I didn't need to be led. Our members have told us quite plainly they are not happy with the situation. They do not feel involved in the commissioning. They do not think there is worthwhile commissioning going on at the moment, and we are very keen that our doctors are involved in the commissioning process. And this is another issue that we have been pushing for.
Right. And how can that be done? You see, I suppose what I'm struggling with is that, you know, we can say, well, we'd really like, you know, enhanced participation in the commissioning process. But it would be helpful, wouldn't it, if we could identify, you know, concrete steps that could be taken in that direction. And I wondered if you had any.
We are looking to build up federations of general practitioners, for example, and engage in general practitioners to help oversee the demands and restrictions. So the GP federations themselves would look upon the services that they would commission and look upon the services that the area they cover require, and then they would commission services and act as commissioners themselves. They may actually provide some of those services and certainly be able to provide them within the primary care network rather than pushing them on to secondary care would be very beneficial, but then they could also act in a commissioning role.
Thanks, Darragh. Some, as you know from the published literature, sometimes there's the suggestion that some staff are subject to a sort of bullying environment. Mm-hmm. That's an allegation. It's in the documents. It's no secret. Yeah. Of course, some say that maybe it happened, but it's not happening now. I'd be interested in your view about 15th of September 2014, whether as a trade union representing your members, whether you hear today, I mean in a contemporary way, not just 2 years ago, whether you hear of credible, plausible, sustained allegations that there's a problem of bullying in some health facilities.
Mm-hmm. There's always, and I think it's been highlighted in the Francis report, for example, that and it's well known that there's always been a difficulty with whistleblowers. The BMA has been developing a whistleblowing policy. It's one thing. It's a matter of concern to us that the sort of people who blew the whistle on things like Bristol, for example, their careers don't prosper, and so people look at it and they think, well, this is what's happened to this person. Do I really want to do this in my career? And we want to encourage people to be able to come forward, to be able to voice concerns. They have to be able, if they see something going wrong, they have a professional duty to speak out. Mm. And we have to be able to let them do that without a fear of menace, or the fact that they're going to be targeted by management, or it's going to affect their career, or they're going to be penalised for it. So it is an issue of concern to us that people are free, and this is something that we have advocated, that people are free to voice concerns. I mean, very much so. I mean, we're talking about governance issues. Maybe I should have made myself a bit clear. We have been working with, for example, people in the Department of Public Health, Caroline Harper, for example, Dr. Caroline Harper, to look and see how we can implement things like Francis, how we can bring forward that within the framework of the government's 2020 proposals, to try and see how we can ensure that people are able to voice concerns, because it's an important aspect of their duty of care to their patient, that they are able to voice concerns and they are able to come forward.
I think everybody would wish that there's an environment in which concerns can be raised. I'm just interested to know whether or not you go a little further than that and say that at the moment, in some institutions, there is an environment which is not conducive to concerns being raised.
I think there's room for improvement. I think there's obviously room for improvement. We saw the sort of highlights in one particular hospital in England, or one particular group of hospitals in England. It would be foolish to assume that that is just one particular case, and that there may be other instances, although maybe not to that degree, within the health service. I think we're all taking a long, hard look, and that's why the proposals and recommendations arising in the Francis report are going to be universally applied. And I think we really do have to take that on board. So it would be foolish to imagine that such things as that didn't happen anywhere else.
Including in Northern Ireland?
Northern Ireland is part of the United Kingdom and the same health service.
Human rights-based, just to draw to a close now, human rights-based approach to health is not a panacea, it's not a magic solution to really complicated policy and operational issues. However, there is now some growing evidence that adopting a human rights-based approach contributes to health gains. Let me put it quite low, it's but a contribution towards health gains. And a human rights-based approach to health demands protection of the human rights of the public at large, patients and their carers, and health professionals. I mean, human rights-based approach requires that health professionals have certain protections. And I'm interested to know whether in your advocacy you use human rights in your advocacy, the human rights of your members. You're a trade union, professional organisation. So do you use the discourse of human rights? Do you refer to the human rights protections? Let's put on one side for now, patients and public, but of your members. I mean, human rights entitlements around training, around support, around work-life balance, around terms and conditions. Is that the sort of language you use, or perhaps not?
In our trade union role, we would rely on the law and the legal framework. So we would rely on those terms and negotiations which have been negotiated. But certainly, when we are negotiating those, we would advocate very much on the terms of the morality of what has been asked for, or what has been advocated, especially in terms of that by our employers. You may find that in these days there seems to be more concentration on practical hard tax. One of the things that we advocate, you were talking about a human rights approach to society. The BMA takes a moral stance on issues in the sense of natural justice. And one of the things, for example, we look at in terms of society is health inequalities, for example. So we're advocates on addressing health inequalities within society, and have been, especially on the presidency of Sir Michael Marmot. So we look upon it, the sort of, maybe not in the terms in the legal framework and in the language of human rights.
So why not? Why not? If you're a trade union trying to protect the interests of your members, why rely upon natural justice and arguments of morality, important though they are? And why not explicitly use more of the human rights language? I mean, maybe there are good reasons why not. I'm really interested. But when I quickly read the document, it's a 16-page document from yourself, which is responding to the TYC.
Yeah.
I've read it perhaps too quickly, but it's quite light on human rights. But interestingly, there is a sentence, I can only find one, which is a sentence on the very issue you've just raised where there's a sentence, you write a sentence about human rights or equality of access to health services. We would seek more detail from the board on how the disadvantaged in our society will be reached. Hurrah, that's great. Yeah. That's a human rights issue. But on the whole, reading it feels human rights light. And I'm just curious because although human-rights-based approach is not a panacea, or remember those prefatory remarks that I made. Human rights has a tradition of assisting trade union members. So I'm curious why you don't use it.
Well, it may be something that I think it's something that maybe we use but don't use it in those actual terms. I mean, we want the best possible care for our patients. We want our patients treated with dignity. We want our members treated with respect and dignity. We want them, we've advocated, for example, for proper sleeping patterns, for proper work-life balance. So I think we're actually advocating the same thing. We mightn't use those terms. Maybe we should use that as and quote that specific argument or that specific use. It would be, of course, it's useful. Everybody needs the human rights protected. It's a measure of our society how we protect our human rights. It's a measure of our society how we look after our frail, our weak and our sick, and that's what we're here for today.
Thank you very much, Darragh.
Paul, I've just got one final question, which is just to bring you back to the issue of bullying. I mean, you've said that the culture isn't conducive to whistleblowing and there was room for improvement. I just want to ask you, is that an issue that is across hospitals in Northern Ireland, or are we talking about a small number of hospitals where it's worse than others? So in terms of your members and what you're reporting, is this a kind of all 12 hospitals this issue is arising, or are we talking about a small number of hospitals in particular where the problem is?
I was actually talking about the general issue of whistleblowing, and the BMA has produced documents and policy, and I would be very keen to display those on a UK-wide basis as to how we should protect whistleblowers and how we should encourage whistleblowing where appropriate. And we do have a policy, and I will certainly submit it. But as to specific hospitals, no, I wouldn't be able to give any detail on that.
Okay, thank you. As we've said to all witnesses, we are very happy to take any additional written submissions and would welcome that. And we have a number of documents, and some of them were alluded to this afternoon. So it just remains for me to say thank you very much for coming in this afternoon. That's been really helpful. So thank you.